Bismillahirrahmanirrahim. Today's lecture is about the series of those lectures or short videos which are intended for medical students and junior residents or medicine residents or GPs who on a regular basis deal with the epilepsy patients. So these patients, a good population of patients have epilepsy, but the way we approach it so we can localize or understand, is it a focal seizure or a generalized seizure, and what we need to do to help them more. Initially, the detailed assessment can be done by a subspecialist or a specialist like neurophysician or epileptologist. But for junior doctors, GPs, and residents, I'm going to give you a brief scheme of how I approach these patients in the clinic. So for epilepsy patient, when they are brought to you by a family member or they come themselves, the most important thing in the history what you want to start with is the handedness. So handedness gives you the idea that if it's a focal seizure, from what side of the brain is coming. Handedness is very important in epilepsy and stroke patients. So after getting the handedness is like a right-handed patient or left-handed dominant patient, then I get the rest of the detail, which is the history of present illness. When I take the history of present illness, like we usually ask patients about the onset, frequency, duration, progression or worsening, but in case of epilepsy patients, beside that, most importantly, what you need to do, or the way I divide it, is the spell assessment. Now, there is a pre-ictal or pre-spell time, there is a spell time or ictal time, and then there is a post-ictal or post-spell time. So what I usually ask them is, did they notice any abnormal sensation, any visual symptoms, any paresthesias, any twitching and with the spread, or they didn't notice anything. So pre-ictal phase is very important. What was happening at that time? Was it some stressful situation, or there was something else in terms of the social situation or physical situation of the patient when it all started? Second part is about the ictal phase. During that time, it's usually patient is most of the time unconscious or unaware. So this is what you get from the eyewitness account. So what I do in the clinic, if the eyewitness person is not available, I usually call. It could be a friend, it could be a family member, but the eyewitness account is very important, especially when it comes to seizure semiology. And there could be head turning, because sometimes they don't know what to explain because they are not experts. So you can give them the idea, was there any eye turning, head turning, twitching first, or it was a whole body jerking, or was it a loss of tone? It could be either of those. Additionally, there could be tongue bite, there could be incontinence, which could be a urine or a stool, and that account can be given by the eyewitness person. After that, there is a post-ictal account. In the post-ictal phase, there could be vomiting, there could be drowsiness or loss of awareness, or there is like confusion afterwards, or headache. So you can ask patient or the bystander what happened when the patient stopped jerking, or when there was no more jerking, what was happening at that time. It can last for a few minutes to 30 minutes or even longer, but that also gives you the idea about the type of epilepsy. So what I do is division into pre-ictal, ictal and post-ictal phase of the spell. And then more importantly, what we need to ask is about the past medical history. If there is any history of head injury, if there was any stroke in the past or hemorrhage, or any other reason which can give rise to localization related epilepsy. Next part is medication. If the patient is already known case or known to have spell or epilepsy, he may already been on some medication. So I try to get the detail of that medication and try to understand if there are any side effects of the medication, because it is very important to address those side effects which may be affecting the quality of life, especially if it's a student and he is using topiramate, which is causing slowness and fogginess. He may not be able to perform as well. So I will really think about switching to some of the medicine to give them that academic or what kind of job they do if they feel uncomfortable about that. Additionally, we need to ask about the family history, which is the general scheme of history of present illness. In family history, there could be previous history of seizures in the family, or there could be febrile seizures in the patient. So we need to understand if it's a genetic induced epilepsy or idiopathic generalized epilepsy is a possibility. Then social history is very important in these patients. So in social history, you need to understand if this patient is a student, or he's a laborer, or is he involved in some kind of job where it could be an occupational hazard in case he has a seizure. So try to get that information as much as possible. Also, having an epilepsy means a lot of other issues around that dilemma, because you need to address the depression in these patients. He may not be able to drive because of seizures, so you need to guide them about the alternative mechanism or alternate ways they can manage this. If you're not going to discuss those during the clinic visit, they may still end up driving and having an accident, which is really not nice. Then comes the examination part. So usually epilepsy patients have normal examination. Unless there is a previous history of stroke or head injury, then there could be some exam findings which can guide you about localization related epilepsy. But most of the time the examination in epilepsy patients is normal. Additionally, you need to understand the cognitive status of the patient, especially if it's a kid and there is a chances of hypoxic ischemic insult or genetic epilepsy with cognitive problem. Then you need to understand know the cognitive status of the patient. Seizure precautions. What I usually tell my juniors and in the clinical setting to my patients is that the patient mostly don't die because of epilepsy. The main reason there is a hazard that they may die with the seizure when somebody tries to put something in the mouth like clothes or water or something else, and there is choking. So always ready to explain this part to the patient, so they shouldn't be afraid, because for someone who is having a seizure in the family and somebody notices that, it's really a phenomena where they just may not be able to move or do something. But they may try to put something in the mouth to prevent the tongue bite, which happens in the start of the seizure. So you don't need to put something in the mouth, and you need to guide the family, because if they're going to do that, there could be choking and probable death. So seizure precautions are very, very important to be discussed with these patients, and you can see our other video where we have explained what seizure precautions generally should be taken in these cases, especially driving and putting something in the mouth. Then comes the social issues. As I said, in epilepsy patients, depression is very common. If it's a female patient, there are issues about pregnancy. If it's a male patient or someone who is doing a job, then there could be question about driving or going to job and coming back, or going to college and coming back. So all these information or alternative ways to manage this should be discussed during the clinical session. So it will guide our patients how to manage this medical problem. Patients with epilepsy in an ideal world should live a normal life. So I always guide females about pregnancy, male patients about their driving and transportation issues, and seizure precautions. Hopefully this video will be helpful for the junior doctors and those who want to learn how to take the history of an epilepsy patient. Thank you very much.